about. What about intubation? This constantly comes up. I receive at least a phone call every month of the child in the intensive care setting. Should I intubate or should I not intubate? I think this really has to be factored very carefully. A child who's doing reasonably well, had a bad infection, ends up in the intensive care, I think needs to be given the opportunity, needs to be intubated, needs to be protected, and yes, they can come off the ventilator. Another situation, child really, really sick, has never done well, now requiring intubation. That's a different scenario as compared to the first scenario that I talked about. So we cannot really generalize and say intubate or not to intubate. I think it has to be looked into. Talking to the family, is intubation or long-term tracheostomy something you would like? But do not deny the child who's had an acute process and really can come off that intubator, but needs to be first intubated or the ventilator before it's done. So at times, really, the clinicians are judgmental and want to discontinue or not start treatment if the child is in the intensive care setting. I think we need to be careful when we make those calls. Depending on the need, infuse right away, even if the child, I know I said don't do it, but if the child is really sick, you've got to take the precautions and go forward and do it. And manipulate carefully, as I said, fractures if there's improper handling. And then we forget the importance of ancillary care in the child who's in the intensive care setting. The role of the physical therapist, the speech therapist, the occupational therapist is still a must. The rest of the child still needs to recover while the child is recovering from the process. If there's no central line, I already talked about it, you can manage with the peripheral line because this is an ideal situation as the children are very fragile. So once again, just to put it in perspective, a 2-month-old at initial presentation in the ICU is quite different than a 10-month-old at initial presentation in the ICU. The likelihood of the 2-month-old to do well is really much greater than the 10-month-old. But what's better? The 10-month-old may recover, but may require continued ventilatory support. The 2-month-old has a better chance of coming off. So really keeping this in perspective as we make our decisions is really important. And I think talking about prognosis and how do we really say these children are going to do or the adults are going to do, I've shown this slide, I think, before. It really is the enzyme it works in the intralysosomal compartment. So if we reach a stage, and this is what we call the electron microscopy, and these are lakes of glycogen all out of the lysosome, the enzyme's not going to do its job here. It's quite late for this particular muscle. This stage is what we desire. It's within the lysosome. The enzyme can reach its target. So the likelihood of response in this group of muscles is much more than in this child where the disease is much more advanced. It's not as simple as that. There are other factors. Defective autophagy or a defective clearance of materials that are normally degraded in the body. We are finding out, and this is very nice work coming from Dr. Nina Rabin, is that there is this buildup in type 1 versus type 2 fibers. Something else we have to understand, is there a mechanism to change the type 1 to type 2 fibers? Is there something we can do with exercise to do that? Untouched area, very important, but we need to learn. And then I think because this topic was discussed as much as it was yesterday and today, what is really the role of cross-reacting immunological material and what do we mean by that? Cross-reactive immunological material, which I'll call CRIM, when I say it's positive, it means that the person is making some enzyme in the body. CRIM negative is when there is no enzyme which is made by the body. And as you can think about it, it's not possible for the adult to be CRIM negative because they wouldn't be adults. So amongst the children, how big of a problem is this? And how do we really evaluate for it? So this is what we call a Western blot, where we are looking at the protein. And this is what the normal steps are, or these are the normal, what we see in a normal skin fibroblast on a Western blot. This is the protein and the different forms of the protein. This is what we call an infant who's CRIM positive. So you're seeing the protein band. This is what we call a CRIM negative, absolutely no protein band which is seen. So looking at this a priori now, I can really talk to a family and say, I would say, if you just put this child on enzyme, the likelihood of doing well is very, very low. This is not something we could have said even up to last year, but I think now there's a lot of evidence. And this is supported by collecting information through these 10 years on looking at patients who are CRIM positive. So like all of you here in this room who are adults with Pompe disease versus the few who are CRIM negative. And you can see that titers, so this is the antibody titers. So if you look at the titer after 24 weeks on enzyme, you can see that the titer in a CRIM positive individual is about 1 in 600. You look at what a CRIM negative is, it's about 1 in 51,200. Look at this child a year later or at week 52. The titer in the CRIM positive typically comes further down, 1 in 200. Look at the CRIM negative going up further, 1 lakh or 153,600. Look at the titer now at week 64, 1 in 300 for the CRIM positive going up in the CRIM negative. So this is really an issue that we have to deal with. And so I looked at just survival between the CRIM positive and the CRIM negative groups that we followed who were under 6 months, so had the best chance of a response to therapy. And this is the CRIM positive group. This is the CRIM negative group. This is what we call a survival plot. And you can see that the median age of death in a CRIM negative patient or of being on invasive ventilation is about age 23 months, or 26 months actually, this is what my paper says. And this is the CRIM positive patient. And you can see that after the initial drop-off, these are patients who continue to do well over the long term. So once you've shown a good response, there are a few outliers. Over the long haul here, these children have continued to be not only alive, but free of invasive ventilation. So clearly, CRIM negative is a problem. I think as Mark from Amicus just talked about a minute ago, as in Fabry, as he gave as an example, lots of mutations in Pompe disease. And so how do we really handle these CRIM negatives, or how do we deal with this? We're trying to build a database of mutations, and they're all over the place. There are all different private mutations. So how do we really prognosticate? Other than this common African-American mutation, the rest we can now guess, because if it's predicting that it's going to make no protein, we can only guess, and that's what we can tell the families until we wait for the results. And here is where I would say is the hope. And I think this may apply not just to the infants, but I think also to the adults who are making high antibody titers. I think it will be applicable to other therapeutic proteins outside of Pompe. So I think the lessons we learn from here are going to be critical. What do we mean by immune tolerance? It means we're going to train the immune system to get suppressed and then not go back and make the antibodies. And so there was very nice work, preclinical work done at Genzyme and also done by us at Duke in the animal models to show that there are different strategies that can be used in terms of immune tolerance or immune tolerizing the system in infants with Pompe disease. And I think in the CRIM negative patients, it's justifiable. So whenever we're doing something, we have to remember we're dealing with humans. And in a CRIM negative patient where we know the response is not going to be good, I think it's justifiable to say we need to step forward and do something to help these infants. And so there are protocols that I think Paul talked to, which are post-marketing commitments of trying to treat these patients. The ideal setting would be before they make any antibodies, before they've been exposed to enzyme, what we call prophylaxis, like we do prophylaxis against certain by taking vaccines to prevent disease. The second situation is we've not caught the patient in time. They've started to make antibodies, but that's another place we can get them and make an attempt. And so these are the ongoing commitments from Genzyme. The challenges is that CRIM testing is not commercially available. It's currently offered, to my knowledge, only at Duke on a research basis under a protocol. The method has been validated and shown to be 100% concordant with work at Genzyme, so 2 labs have worked closely together. It takes about 6 weeks to get an answer, which is too late for the infant. The good news is that now we have some mutations which are predictive, and we can work on that. So we really need to increase awareness about this so that we can get the appropriate intervention in time for the children. And so this is outside of a protocol. I just want to show you the hope. This is a little boy with Pompe disease with the common African-American mutation. And this is work that I did in collaboration with Dr. Nancy Mendelsohn, and she was kind enough to allow me to share this information. So this child had already received myozyme, had received it at an early age, 6 weeks. And then the first positive titer was noted after 6 weeks, so after 3 infusions. The titer was still low. It was about 1 in 400. So we started talking with Dr. Mendelsohn. And as you can see, is that over time, the antibody titers in this child were starting to go up.